The management protocol of hypoglycemia in infants and children below 14. Management protocol of hypoglycemia in infants and children below 14 from Saudi Arabia, Ministry of Health. The protocol. Definition. Definitions for infants and children, plasma glucose less than 3.3 millimole or 60 milligram per deciliter, measured by accurate lab method. For infants and children, when plasma glucose is less than 3.3 millimole or 60 milligram per deciliter, measured by accurate lab method. For neonates, refer to Ministry of Health Neonatal Hypoglycemic Protocol. Presentation. In a newborn, hypoglycemia present as apnea, cyanosis, bar feeding, sweating, tremors, jittering, irritability, convulsion, coma. In infants and children, irritability, dizziness, blurred vision, difficult speech, headache, confusion, feeling faint, personality changes, palpitation, hunger, nausea, sweating, anxiety, dream, paralysis, nervousness, ataxia, drowsiness, and convulsion and coma. The diagnosis is by reliable blood sugar estimated during symptom assessment. History: neonates, prematurity, intrauterine growth retardation, maternal diabetes, perinatal stress, example birth asphyxia, sepsis, shock, fasting, hypoglycemia or hypoglycemia after meal, and hyperinsulinemia, diabetes mellitus, renal insufficiency or failure, hepatic cirrhosis, failure, other endocrine disease or recent surgery, drug history, insulin usage or ingestion of an oral hypoglycemic agent, toxic ingestion, new medication. The social history may include intake and nutritional deficiency. Review the system for weight reduction, nausea, vomiting, headache. Look for other symptoms such as infection. Examination. The physical findings are non-specific in hypoglycemia and generally are related to the central and autonomic nervous system. Height and weight, in thin stature, ketotic hypoglycemia. Assess the vital signs for hypothermia, tachypnea, tachycardia, hypertension, and bradycardia in neonates. The head, eye, ear, nose, and throat examination may indicate blurred vision, pupil normal to fixed, and dilated, icterus, usually cholestasis due to hepatic disease. Cardiovascular disturbance may include tachycardia, bradycardia in neonate, hypertension or hypotension, and dysrhythmia. Midline congenital anomalies, ambiguous genitalia, micropenis, facial anomalies, cleft palate, central incisius, nystagmus. Respiratory disturbance may include dyspnea, tachypnea. GI disturbance may include nausea and vomiting, dyspepsia and abdominal cramping, hepatomegaly, glycogen storage disease, any abnormal mass. Skin may be diaphoretic and warm or show sign of dehydration with decrease in turgor hyperpigmentation. Neurologic conditions include coma, confusion, fatigue, loss of coordination, tremor, convulsion, and diplopia and cataract in case of galactosemia. Investigation: obtain 5 to 10 ml blood, red top, and 20 ml urine for further investigation to be safe for 48 to 72 hours. Critical sample: acute blood and urine test at time of hypoglycemia. Blood chemistry panel with bicarbonate, insulin, C-peptide, cortisol, growth hormone, free fatty acid, beta hydroxybutyrate, acetoacetate, lactate, ammonia, total and free creatinine, acyl creatinine profile, severe serum tube. Urine: the first urine voided during or immediately after the hypoglycemia event should be collected and tested for ketones, if blood ketones will not be measured, and urine organic acid. The management plan. Hypoglycemia, blood sugar less than 3.3 millimole. Collect blood sample for investigation, blood gas, insulin, MOH, lactate FFA. If the patient is conscious and symptomatic, send the blood sample for glucose, offer feeds or sugary drink for older children. We check blood sugar by 15 minutes. Impaired consciousness, convulsion, or coma. Collect sample of blood for investigation. IV glucose from 10% exposed normal saline, 5 ml per kg over 3 to 4 minutes, followed by D10 normal saline in maintenance. IV repeat blood sugar after 15 minutes. If there is no response, repeat the D10% dextrose bolus. If still no response, increase the rate and concentration of glucose infusion. If it is more than 12.5% of glucose infusion is needed to maintain normal blood sugar, insertion of central line is advisable. If no response, start glucagon injection as following. The weight of child less than 20 kilograms, give half milligram subcutaneously, IM or IV. The weight of the child more than 20 kilograms, give 1 milligram subcutaneous, IM or IV. The dose of glucagon may be repeated in 15 minutes if necessary. Repeat blood sugar every 15 minutes. Once the blood sugar is controlled, oral feeding should be started. Glucose infusion should gradually discontinued. Try to find the cause of glycemia. Consult pediatric endocrinologist. In ketotic hypoglycemia, it is the most common cause of childhood hypoglycemia. It usually presents between the age of 18 months and 5 years and remits spontaneously by 8 to 9 years of age. Hypoglycemia usually occurs during illness when food intake is limited. Diagnosis is confirmed by fasting for several hours under close supervision and collecting blood samples for testing at the time of hypoglycemia. There is associated ketonemia and ketonuria. As lanine levels are reduced, treatment consists of frequent feeding of high protein, high carbohydrate diet. Thank you.